So this is my position. Transition to adult care is bad for the health of HIV-positive youth. Again, that's the yes vote on Menti. I have no official conflicts of interest to disclose, but I think it's fair to tell you that I'm a pediatrician and may be biased accordingly, at least in some of your minds. So I think it's important to spend one more moment thinking about what transition is. So sometimes when we refer to transition, we think of shifts from pediatric focus to adult care settings, which is what we're talking about today. We also, though, think of transition as the process of taking more responsibility for one's own disease management and the developmental transition of moving from childhood to adolescence to adulthood. But again, our statement today is related to care settings, that transition to adult care is bad for the health of youth living with HIV. I have lots of reasons, so I'm going to have to go through them and the many, many scientific studies on my side very quickly. So transition to adult care is bad for retention. If you look at the results from high-income countries, you see numerous studies that are showing increases in missed appointments, more patients being lost after the first year of adult care, and really across the board, not good rates of loss to follow-up. 14% in a study from Spain, some smaller studies from Italy and Canada with almost 25% loss to follow-up at 4 years following transition. A study in the US had about 50% who were lost to follow-up by the time they were in 2 years. And we just see increasingly that it's a problem in these studies for retention. Transition's also bad for retention in low and middle income countries. We have fewer studies from these settings that report loss to follow-up outcomes after transition, but those that do are by and large showing negative effects. In the Dominican Republic, not only was there 10% loss to follow-up, but transition to a different site for adult care was associated with a higher risk of death and loss to follow-up. South Africa, you see declines in retention. In Uganda, you again saw as high as 25% loss to follow-up despite the use of a transitional clinic with youth-friendly services. Transition doesn't help our immunologic outcomes. We see significant decreases in the mean CD4 after transition in several studies there from the UK, Canada, and South Africa. In a small US cohort that focused on details related to 14 youth who had all died post-transition, the dramatic decreases in their mean CD4 were seen in the immediate follow-up after their transition year. And even in studies where they may report higher CD4s after transition, like this one from Italy by Icahn, it's important to note that at follow-up, the denominator only includes those who are retained to care. So you start to see just this biased group that's actually sticking with the adult care. But I have many more reasons to go through. Transition does not help viral suppression. Most studies show either no improvement in viral suppression after transition or less viral suppression after transition. With studies here from South Africa, where viral suppression was decreasing at 3 years, the Dominican Republic, Brazil, where more than half of the patients were not virally suppressed at transition and adherence continued to be bad after transition. And then large unpublished results, but that are coming soon from Southern Africa with over 5,000 patients where there were no differences in viral suppression. We see lots of deaths after these transitions. So again, in that study from the Dominican Republic, it was associated with death. And we see rates of mortality between 2 and 9% in studies that are reporting transition outcomes. Perhaps most important of all, I would argue, adolescents don't like these transitions. In studies from across the world, we see adolescents saying that 18 is too young for transition. They identify mental health challenges, provider relationship disruption, stigma, perceived judgment from adult patients. In one setting in Kenya, not the study where I work, so I'm not completely biased, but another study where almost 70% had transitioned to adult care by 19 years, most reported they felt unprepared and experienced considerable anxiety after transition. Issues raised in Uganda by youth included fear of abandonment, loss of peer support, negative perceptions about adult care, such as having to deal with longer wait times. And there's a lovely poster here by Dr. Biema Sophie, poster number 85, a qualitative study from Kenya that has a title that summarizes it with a quote from their study: "They will look at you with eyes that will make you want to run away." That's how the adolescents feel. Transition to adult care can raise more mental health and substance use challenges. We know that adolescents living with HIV experience higher rates of substance use, mental health problems, difficulties in adjustment, and reduced emotional support compared to both adults living with HIV and compared to their uninfected peers. And yet, when we look at sites from across sub-Saharan Africa, there's a lack of provider training in mental health services for adolescents and lack of disclosure support for adolescents, particularly in these adult clinics. Moreover, their mental health and substance use challenges make it even worse during transition. And many adult care settings lack coordinated services for mental health. Transitioning in this way might add to the loss and trauma that our adolescents are already experiencing. The feelings of loss with separation from their healthcare team is something that's frequently cited by the youth, and this may be particularly problematic for youth who've already lost parents and caregivers. This becomes a major challenge. And youth also report considering it traumatizing when they have to discuss their history, all that goes with it over and over again as they enter the adult care system. This transition may push adolescents into new structural and systems issues that do not benefit them. This varies what these look like, of course, according to the system you're talking about. In the United States, there are significant structural barriers to care for adolescents, including insurance eligibility, transportation challenges, differences in HIV stigma. In the US, young adults are twice as likely to be uninsured compared to children or adults. And there may be particular gaps in insurance coverage related to whether you've disclosed HIV to your insurance providers. Adolescents are also pushed into dealing with HIV criminalization laws in many settings in different ways when they're forced to transition. They may experience inconsistencies in their medical treatment. A lack of communication between providers in these transitions is cited. And in a study from the US with 14 clinics, the transitioned youth described poor interclinic communication about their care. In a study from the esteemed Dr. Judd here that looked at adolescents after transition in the UK, less than half of them could name their ART drugs or their most recent CD4 and viral load, even though they were reporting more self-management after transition. I would argue that these youth are not able to fully help their adult providers with the information they might need. Moreover, adult providers may not be trained in key treatment supports like adolescent disclosure. They might experience more stigma. I couldn't find good quantitative data about this, I just couldn't find studies, but there are a number of qualitative studies where youth report that they anticipate or perceive that there's more stigma when they access adult HIV care services. This was cited in studies from South Africa, from Uganda, from the US, and this may be heightened for perinatally infected youth. Moreover, adolescent brains are not ready for this transition. They are not yet adults. Their precortex, which, as we've been talking about, coordinates their higher order cognitive processing and executive functioning, needs to mature through myelination, and that is not complete in the prefrontal cortex until their early 20s. Without this, they're just not ready. So in summary, why is transition to adult care bad? I could go on, but here's the quick and terrible list. It's bad for retention, bad for immunologic outcomes, no help for viral suppression, and maybe makes it worse. There are lots of deaths. Youth don't like it. It's bad for mental health. It adds to loss and trauma. The structural and systems issues are more problematic. There are inconsistencies in treatment. There's more stigma, and their brains are not ready. Now, I know you might be thinking there's a big high-income versus low-income country difference here. Despite the differences in how the care systems are structured and the times that many of these places have been providing care for adolescents, the studies that I've cited and that are currently available would suggest that the impact is the same. So again, in the face of these many, many potential risks, I would argue, why push something risky for a population that's already at great risk? Thank you.